Hi everyone, welcome to the wrap-up session of the KSC 2018. I'm Myungjin Cha from Seoul National University Hospital, and we invited 4 experts about NOAC. And please introduce yourself, please.
Dr. Matthew Rowe from the Duke Clinical Research Institute in North Carolina in the United States.
Robert Welsh from the University of Alberta Hospital, Mazikowski Alberta Heart Institute in Edmonton, Alberta, Canada.
I'm Kiyomi in Cheonnan Yushin University.
Hi, I'm Young Jung from Gyeongsang National University Hospital.
Okay, thank you. So we know we have the excellent lectures yesterday, and I want you to summarize your lecture yesterday, please.
Okay.
Thank you.
So I had the opportunity to speak about the use of novel oral anticoagulants for the treatment of chronic coronary artery disease and peripheral vascular disease. And mostly I spoke about the COMPASS trial that was performed and presented last year. This trial was testing the regimen of aspirin alone, aspirin with low-dose rivaroxaban, and then rivaroxaban 5 milligrams twice daily. The trial was stopped early by the Data Safety Monitoring Committee due to overwhelming efficacy seen in the arm with aspirin and low-dose rivaroxaban 2.5 milligrams twice daily. What was seen in that study was there was a significant reduction in mortality and composite ischemic events in this treatment arm, not only in patients with chronic coronary disease, but also those patients who had peripheral arterial disease. Additionally, major adverse limb events were reduced in the latter group as well. There was a significant increase in the bleeding risk, but the ischemic benefits were thought to outweigh the bleeding risk. That's why the trial was stopped early, and I'm pleased to announce that yesterday this treatment regimen was approved for use in the United States by the FDA. So I think we talked about patient selection, when this treatment regimen should be started, how long patients should be treated for, and how we make decisions to use this regimen in our practice, and I'll look forward to discussing that further during the session today.
Okay, COMPASS trial is very important trials for the physicians, but we have still very controversial or debatable issues about this trial, and the most important thing, the bleeding issue about rivaroxaban. So what do you think about the bleeding issue?
I would like to add one comment. Actually, I performed the subgroup analysis for COMPASS. Actually, in COMPASS trial, maybe almost 20% of patients from Asia.
Yes.
So if you look at each compound, almost 80% from East Asia. It's kind of my hot content of my field, because I'm so focused on the East Asians, the clinical efficacy, especially safety. I performed the analysis to compare the low-dose NOAC, the clinical efficacy and safety. The Asian, they showed almost similar ischemic benefit by adjunctive low-dose rivaroxaban. However, if you look at the bleeding, almost 1% is more increase in Asian population. So low-dose rivaroxaban looks good, but we still have some concern, especially in East Asian.
Sure.
So one of my concerns is related like this: how can we prevent this kind of bleeding, especially in high bleeding risk patients such as East Asian? Actually, how do you think about the role of PPI?
Sure.
Because almost 40% of bleedings related with GI bleedings in COMPASS trial.
Well, as you know, there was a secondary randomization in COMPASS to a proton pump inhibitor versus placebo that was blinded. That part of the study continued beyond the main trial, and those results are expected to be presented next month at the American Heart Association meeting. So we look forward to seeing those results, and if the use of a proton pump inhibitor reduces the risk of GI bleeding, I think that can make the regimen more safe. However, I would follow up on your comments to say, what factors do you think are driving the increased bleeding risk seen in East Asians? Is it lower body weight? Is it older age? What's driving that observation?
It must be so complex, but there are so many postulation, how can he explain this kind of the disparities, especially in East Asian, multiple factors. But one of the issue, the more risk of hemorrhagic stroke is a kind of a unique characteristic of East Asian because there are a lot small vessel disease in brain in East Asian. Another issue related to more GI bleeding because H. pylori infection rate in East Asian over 50%.
Okay.
It's such higher compared to the Western population. Another issue related with the pharmacodynamic of NOAC. It's almost similar with other cardiovascular drug. If you look at each cardiovascular drug's pharmacokinetic and pharmacodynamic profile in East Asia, mostly it's almost 20 to 30% increase in East Asia compared to the Western population, even after body weight adjustment. So I don't know, how can you explain? The body weight has some role, but even after body weight adjustment, still the drug level in blood still increased in East Asia, 20 to 30%.
Yes,
Actually,
These kinds are also related with increased risk of bleeding.
Yes, there were some observations for warfarin users. Lower INR was suitable for East Asians. There were some reports. And I know, Dr. Lee, you have many Korean data, Asian data about the OAC users.
Yeah.
How about your opinion?
Actually, the mechanism in case of warfarin, maybe the difference of bleeding is maybe explained by the genetic polymorphism. Also, the genetic polymorphism, the genetic component is different from the Asia and the non-East Asia. So, when we use the warfarin, although the same INR level, the Asians are very prone to develop the major bleeding. So, it is that the story of the warfarin. However, nowadays the era of the NOAC, so we don't know why the East Asian people are prone to develop the major bleeding. So, so we have to confirm the why East Asians have the more bleeding risk than the Western population. Also, Dr. Jung already said that the most of the clinical trials, such as the COMPASS trial, the component of East Asia is very small. So we cannot confirm that the addition of levodopa, although there is the low dose, we cannot say that this addition of the levodopa to East Asian population is really good or not. What do you think about that?
No, I think it's an interesting observation. We talked about this yesterday, and I think partly you're right. We don't have enough representation in the large trials from East Asian countries, and we need to change that. We also don't do a very good job in early phase testing to really try to optimize the drug dose. You know, in most other drug classes, say blood pressure medications or diabetes medications, we typically have multiple doses we use for patients based upon their treatment response. But with antithrombotic therapies, we typically just have one dose, and one dose shouldn't fit all patients. And so we need to do a better job early on in phase 2 trials for dose selection to find the doses that fit best for the certain populations. And then when we do the global studies, customize the dose used for the patient and have some type of marker to indicate a similar drug exposure, as you were saying, that the pharmacokinetic exposure may differ, and therefore the pharmacodynamic exposure would definitely differ.
The bleeding story, though, in COMPASS, and maybe there are some differences in COMPASS than the other trials, but the bleeding story is very clearly increased. There's no debate. But I would argue that the modified ISTH criterion is quite a sensitive criterion for bleeding, and it's a lot different bleeding than we use for ACS trials, like TIMI major bleeding, which is a true life-threatening bleed. And if you look at the fatal bleeding and the ICH, it's neutral, very neutral. And the other thing different about COMPASS is, that, as you said, almost 20% of the trial was actually in East Asians, which means we've got a population of, 6,000, 7,000 people that were East Asian in the COMPASS trial. So we should be able to look at this. So I'd be curious with the increased bleeding.
But my data is published in NEJ. We can find it.
Excellent. Was it ICH increased fatal bleeding, or was it the ISTH?
Actually, I cannot find the details. I'm just focused on the global data.
Because that would be very interesting to see the type of bleeding as well. And the other thing about bleeding, and I know this is a bit tongue-in-cheek and we have to be careful, but John Eichelboom flipped it a bit the other way at ESC this year, and he looked at the impact of bleeding, and he actually showed that there was more people with early stage cancer diagnosed, and that you may actually save people's lives by causing bleeding because of early diagnosis.
Sure.
Now, we've been talking about this forever, but there's now some evidence to support it. And the other thing about bleeding, and again, not to downplay the importance, if the bleeding signal was strikingly strong, then your all-cause mortality would obviously be more neutral. Whereas in COMPASS, your all-cause mortality, which includes ischemia and bleeding, comes out very positive.
Yeah, I think that's a very good point. But if you go back to the story with prasugrel, in the Triton study, there was an increased risk of cancer seen that was unexpected. It was primarily GI cancers, and they were primarily detected from the GI bleeding. So when we did the Trilogy study, we actually looked at this prospectively and showed no difference in cancer event rate. But I think it is an interesting hypothesis, and that is if you expose someone to the COMPASS regimen, you may pick up early stage gastrointestinal cancers that could be cured through surgical treatment because they're picked up early, whereas they wouldn't be picked up until later when they've metastasized if they weren't on that regimen. So you kind of turn that around a little bit and say it may be protective in some sense, but it is instructive that patients who have vascular disease are also patients who have cancer or at risk for cancer, and those things coexist, and that may be explaining some of the GI bleeding. That also may be part of what's being seen perhaps in the East Asian population, perhaps it's more gastric cancer or colon cancer, I'm not sure.
Cancer breakup, isn't it?
Yeah. So, yeah, and I like your idea about the small vessel disease. I mean, it's been seen certainly that the risk of hemorrhagic stroke is higher in East Asian patients. Could it be that they've had untreated hypertension and they have more small vessel disease? Is the blood-brain barrier more fragile, maybe more prone to that? We're not sure, but it certainly are observations that require further study.
So it's very practical question. Although both of you are the study of the rivaroxaban, however, the bleeding risk of all four kinds of NOACs, maybe the apixaban or edoxaban had the lower risk of the bleeding. So if your patient had a very high bleeding risk, do you prefer rivaroxaban or apixaban?
Yes.
Well, I think you have to be a little cautious about cross-trial comparisons. We all know that. But I think the striking message is that your bleeding that counts the most in an Asian population, the biggest bleeding risk is ICH with warfarin. And if you look at the way it was studied in either the Japanese patients in ROCKET, so J-ROCKET, a slightly lower dose, consistent with the lower INR dose, it looks very compatible or attractive. So I guess it comes down to that, but it's clear that the apixaban dose studied in the population in the trial had a very nice safety signal. So you've got excellent options, and then doxaban as well. So you have to be...
Yeah, I'll say in the United States what we've seen is that the lower dose of apixaban, 2.5 milligrams BID, is used too widely. There are three criteria that we use to decide who should get that, and they have to meet two of the three, and that's an age greater than 80, lower body weight, and lower creatinine clearance. And what happens in the U.S. is that the lower dose is used for people who truly shouldn't be on that dose because of concerns about safety, and those people may not be having an effective dose to prevent stroke and atrial fibrillation. So we have to, try to balance that out, and there is this idea that apixaban is safer than rivaroxaban because of this dose reduction, but we forget that we can reduce rivaroxaban, and those two have never been compared head-to-head, so you can't really make that claim. Although we hear that a lot, I think the safety has to be looked at within each agent and not across the agents in terms of comparisons.
Then both of you, the conclusion that both of you do not prefer any kinds of drug, apixaban or rivaroxaban is both okay, isn't it?
I use it both equally in my practice.
Okay.
Okay, this is very important issue, but we don't have much time. So what about moving to the next issue? I and Dr. Lee is electrophysiologist, and we have many AF patients, and maybe you have many patients with PCI or coronary artery disease or peripheral artery disease. many patients have both of the disease, and guideline says after PCI or after diagnosis of the CAD, they recommend the antiplatelet with OAC or OAC only or many sorts of things. So what's your opinion on the current guidelines for those patients with both disease?
Well, I can start this one, but I will state right up front that I'm a bit of an extremist on this, because I do think this is one of the situations where the guidelines have ignored the randomized trials completed to date in their consensus. So if you go through the trials, WOST, which had a smaller percentage of ACS, mostly stable patients, really was an at-hospital discharge dual pathway approach with warfarin and clopidogrel. The ISAR trial was 6 weeks versus 6 months, so a different design again. Pioneer and Redual, the other two that are presented, really you applied the new strategy at hospital discharge. So the dominant strategy from Pioneer being 15 milligrams with clopidogrel, which is the one that's been applied most broadly. And in Redual, the same thing. The vast majority of patients went to double therapy at hospital discharge, although there was a proviso in Redual that you could continue triple therapy for up to a month. So if you look at our trials, most of them are consistent that you go to an antiplatelet and an anticoagulant at hospital discharge. And Pioneer had almost 50% ACS, so we've got a fairly robust sample. But physicians and guideline committees are very uncomfortable changing to that strategy. They're still recommending 1 month to 6 months of triple therapy in the setting of every single trial that we have, not testing that strategy. So I'm a bit of an extremist on this, and I have to admit that it surprises me people's reluctance to give up on a therapy which we know at least triples bleeding and has no efficacy signal that I'm aware of.
So Rob, if you have an ACS PCI patient who also has atrial fibrillation versus an elective PCI patient who also has atrial fibrillation, do you change your decision making around triple therapy? Like, do you use a month in the AS PCI patient?
So for the stable patient, the event rate is so low that I don't even think about it. They go on either clopidogrel and rivaroxaban 15 is what I standardly use, or if they had complex stenting with lots of metal, then I might actually go to Cagrelor and rivaroxaban. Again, I know I'm a little bit of an early adopter. In the ACS patient, they're usually in hospital for close to 5 days. So I would typically continue triple therapy in hospital and stop it. And what you would remember, obviously, I mean, we did Gemini together, is that you do expect the antiplatelet of aspirin effect to last another 7 days, so it's almost 2 weeks anyway. So the exception would be someone, again, with a ton of metal, where you've had to do very complex left main bifurcation, and they're low bleed risk, where I might commit to a month. But I definitely don't commit to 6 months or 3 months.
And you mentioned ticagrelor and rivaroxaban, or ticagrelor and apixaban. Obviously, those really haven't been studied, but do you feel comfortable using that together with the NOAC?
Yeah, so what we know from Pioneer was about 4% of people on ticagrelor, so small numbers. Redual was actually quite a bit higher, and there was no signal that one was better or worse than the other. And then if you look at bleed risk, we know you get more bleeding with ticagrelor, but you also get, at least in patients that are potentially resistant, my fear with clopidogrel is that if you get a platelet resistance and now you don't have the aspirin as a backup, then you're really an anticoagulant alone. And I mean, we all know that the evidence to support change in practice by platelet function is weak or non-existent. But still, there's a physiological think. You don't want no antiplatelet effect in 15% of your patients. So, you know, I do tend to go with it, but not in a high bleed risk patient, to be clear.
Actually, I have some different opinion to you, because ticagrelor. So actually, in my hospital, we measure the all platelet function for all PCI patients. So during PCI and after 1 month. If you measure the platelet functions during ticagrelor treatment, their mean PRU is like 30 PRU. 30 PRU.
Okay.
So less than 10 PRU, more than 50%. That means the current standard dose of ticagrelor looks too strong. So if you added, even though somewhat low dose of NOAC, this kind of combination must be harmful due to the increased risk of bleeding. So I'm so favor of the concept of ticagrelor, but if you wanted to use the ticagrelor for your ACI, PCI patients, in AP patients, so you need to cut down maybe
You go to 60 milligrams?
No, maybe half.
Okay, half. Okay.
Half is still strong than clopidogrel.
Okay.
I also agree your opinion that the European guidelines recommend the P12 of choice is clopidogrel. And although the Lydio PCI or the Pioneer trial, they permitted all kinds of the P12 inhibitor. However, as Professor Zhang said, the use of the prasugrel or ticagrelor maybe increase the risk of major bleeding. So, and I wanted to ask another question. The OS monotherapy after 1 year is all guidelines recommend.
Yeah.
However, we do not know the OS monotherapy is enough, or we need the single antiplatelet agent. What do you think about that?
Yes, we debated that yesterday, and
Yeah.
I'm uncertain about that. I don't practice that in my own practice. I look at the risk of stroke with atrial fibrillation as a cumulative risk over time. It's a low risk, and the more time you're in atrial fibrillation, the greater your risk is over time. But then I look at the ischemic vascular disease risk, and we know in patients who have chronic coronary artery disease, the risk of a major adverse cardiovascular event is about 3% per year. That's much higher than the risk of thromboembolic stroke and atrial fibrillation. So if I'm treating a patient with full dose oral anticoagulant for atrial fibrillation for the rest of their life, I have no data that that's actually an effective therapy for chronic coronary artery disease. So I therefore feel that those patients should also be getting aspirin at that point. The only patient where I would do that in would be a very elderly patient who's had stable coronary disease without an ischemic event for years. But I'm uncomfortable with that, and I stated that yesterday, and I think there are no data at all to support that. So I'm curious as to how that got into the guidelines or the consensus statements.
Well, the main driving factor for that recommendation is they took the AFib trials in people with coronary disease and showed that they had increased bleeding risk. But that's a very different discussion than an ACS patient, which we know has an ongoing risk that's probably 3 times higher than a true stable or chronic coronary artery disease patient. But I really like the way you've taken that, because we looked at a very high risk for thromboembolic event patient population, those with AF and decreased left ventricular function after STEMI. And we expected that stroke would be a dominant thing, but actually the recurrent coronary events were 3 times more likely than stroke. So I really like the way you laid that out, Matt. It's a nice way of thinking of it.
I think we know that stroke is devastating, and we want to prevent that. And so all of our treatments for atrial fibrillation focus on full dose anticoagulation for the rest of their life, even if they have paroxysmal atrial fibrillation, even if they've had ablation, because we know ablation doesn't cure atrial fibrillation. But yet, we forget that they also have atherosclerosis that's not going away too, and those treatments need to be lifelong as well. And so that's the way I look at it. I look at that as related, but different disease states that require different approaches. So I think we should keep that in mind, and when we select therapies. And you're an electrophysiologist, I understand. You're focusing upon atrial fibrillation. I'm a general cardiologist who takes care of patients with coronary disease, so I look at both. And I think we should all learn from each other in that way.
And maybe in this year, TCT, one clinical trial result was published, maybe a fire study in Japan. Maybe
I would like to introduce the result. It's a Japanese data. And OAC alone, they know about 800 patients, and they randomized the AP PCI patients after 1 year. Just keep going, just oral anticoagulant monotherapy, and then they added a single antiplatelet agent to oral anticoagulant. It's just my feeling like this. Maybe the Japanese people, maybe the results are almost similar But if you look at the result, it's so interesting. Small size data, but some patients show the increased risk of thrombotic event, such as MI and the stent thrombosis. But even though there are some increase of bleeding, some cases are more thrombotic event, some cases are more bleeding. So even though this study enrolled some low risk of Japanese patients, I believe we have some space to use anti-platelet agent even after 1 year,
Sure.
such as AMI patients and multiple stent.
Yeah, it's interesting.
Should the asthma burden like this?
An interesting twist on this, and I'm not recommending it, but grounds for another pragmatic trial would be to take the Pioneer strategy of 15 milligrams and a single antiplatelet long term.
Yeah.
Because if you think that in an AFib patient, you obviously don't want to get rid of the anticoagulant, but if you're convinced you don't want to get rid of the antiplatelet, what would be the right combination and doses? And maybe 15 and an antiplatelet would be attractive.
Yeah, I mean, I think you're right, and I believe that we commit a patient for life to anticoagulation with atrial fibrillation. As they get older, the risk of thromboembolic stroke increases. We know with the CHA2DS2-VASc score, age has a big impact on that. But then the risk of an ischemic coronary event increases as well. So it's a tough population to treat.
And the risk of bleeding goes up, if anything, more.
I mean, it's
a new trial.
No, I think we've come up with about 15 new trials we should do just at this meeting in the last 2 days. So what would be fun is to do those trials concurrently, work together with you in Korea and other countries,
and
so that we have a better proportional representation of patients. But yeah, I think I'm a clinical trialist, so I'm always coming up with new ideas to keep myself in business. But also, I think we're all here because we want to take better care of our patients, and we want to help our colleagues do the same thing. So these types of discussions are most helpful in that regard. As we mentioned today, that there's no clear right or wrong answer here, but we certainly can do better than what we've done in the past because we have more data to empower us.
Okay, we have only 3 minutes.
Okay.
So during the last 3 minutes, we want you to anything you can tell the Korean physicians, and anything you wanna share with us your knowledge.
I don't have a big ending moment, but I would like to say that the meeting has been quite impressive, and it's been a joy to be here, and the scientific engagement's been wonderful. So thank you.
Yeah, I would just say to our colleagues in Korea that we share a lot of common interests, and we would look forward to doing some analyses where we look at data from the United States and Canada, compare those to data in Korea, and I've had the opportunity to train 3 cardiologists from Korea at the Duke Clinical Research Institute, so we'd love to train further colleagues and exchange thoughts and ideas and work together. So it's really an outstanding meeting, and it's a pleasure to have been involved in it.
Actually, in the America, the United States just says the AH or the ACC. We don't have enough opportunity to present our result, the East Asia's result. So I suggest to you that could you invite us to present our data in
Sure.
the AHA?
I will talk to the people that I know, but Dr. Welsh and I don't organize those meetings. But I think there's opportunities for the societies to collaborate more and have symposium sessions where we can do that. We certainly would love to influence our colleagues in that regard.
Thank you.
And we can ask Dr. Stone about that for TCT. He's here, and I know he would like to do that for TCT, where he is the program chair every year. So.
Okay.
As for you, I'm a guy for the blood. Actually, I'm so happy to meet you, this kind of world expert, because when I just started my research 10 years ago, I'm so alone. So alone. Still, I'm so alone. But there are big concern for the blood. It's a thrombocardiology. It's a new world to improve our patient outcome. So Dr. Lee already mentioned the concept, the pathophysiology in human bodies is almost similar, but the East Asian doctors, they try to more focus on the balance between efficacy and safety. So in this point, we need to make a more collaboration and some the artists, including multi-ethnicity together. So this kind of concept improvement can give more clinical benefit for whole world, the people.
Okay.
Great, thank you.
On behalf of our society, thank you for coming and thank you for spending your valuable time with us and giving us nice lectures. We can meet these two experts during the rest of the KSC. Thank you.
Thank you.
Thank you.
Thank you.